So good morning, everyone. Thank you, everyone, for joining, and welcome to October's Journal Club. First, the land acknowledgement. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, and the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. We have two outstanding geriatric medicine subspecialty residents presenting today. Our first speaker is Dr. Rachel Johnston, PGY5 and future Orangeville geriatrician, who will be presenting first on the association between alcohol, brain iron, and cognition. Rachel, please feel free to go ahead.
Thank you so much for the introduction. So as Dr. Gandel said, I'm going to be presenting on the associations between moderate alcohol consumption, brain iron, and cognition among UK Biobank participants and observational and Mendelian randomization analysis. This was published in PLOS One a few months ago. Okay, I have no disclosures. And our objectives for today, so this is the short presentation. I hope that we can redefine low-risk alcohol drinking in light of the updated 2022 Canadian guideline, briefly discuss proposed mechanisms for alcohol's impact on cognition, and review novel approaches to cohort study analyses, including observational, causal-mediated analysis, and Mendelian randomization. Then we will critically appraise the observational cohort study. So I always like to frame it in a case. Imagine you're seeing an 80-year-old female who complains of subjective memory impairment. She says she drinks 1 glass of red wine at dinner for her health, and she scores 27 out of 30 on the MOCA. And she asks, what can I do to prevent dementia? Thinking specifically about the alcohol. So just to frame alcohol in Canada, it's a legal psychoactive substance. Its use has been normalized across mainstream culture, such that 75% of Canadians consume alcohol. And we see this in religious depictions, politics, and Hollywood. Unfortunately, alcohol is the leading cause of preventable death, disability, and social problems. So 18,000 deaths per year in Canada related to alcohol, and it costs our system $5.4 billion per year, and that's from 2017. We know that too much alcohol consumption is related to poor cognitive outcomes like alcohol-related dementia and alcohol-induced persisting amnestic syndrome, also known as Wernicke-Korsakoff syndrome, secondary to low brain thiamine. In 2020, the Lancet Commission came out with this really nice diagram on the right that you can see of different risk factors for dementia across our lifespan. And they outlined alcohol consumption of more than 12.5 units per week in midlife as a risk factor for alcohol. And I'll just highlight here that the units in Canada and the UK, where the Lancet paper came out of, are different. So in Canada, 1 unit of alcohol is 13.5 grams, and in the UK it's much smaller, it's 8 grams. So I've made those conversions because the paper is a British paper relevantly throughout the presentation. So this leads us to wonder, like, how does alcohol actually mediate changes in cognition, and how much is too much alcohol? Can everybody hear me okay? I just want to make sure.
We hear you very well.
Okay, perfect. Sorry, there's a little bit of background noise. So for the first question, how does alcohol impact cognition? We know that thiamine deficiency has been implicated in alcohol-related brain damage. There are other proposed mechanisms as well, because it looks like thiamine might not be the whole picture. So whether chronic alcohol causes direct neurotoxicity, whether alcohol sets off a neuroinflammatory cascade, are all possibilities. Maybe more recently, people have been talking about iron-mediated oxidative damage known as ferroptosis being implicated in alcohol-related disease. And that's what brings us to this paper today. And so I want to highlight on the right the regions of the brain with the greatest iron deposition. So there we're looking at the hippocampus and the temporal lobe, the basal ganglia, and the thalamus. Those are really our areas of interest when it comes to iron in the brain. And our second question is, how much alcohol is too much? So over the last several decades, there's been increasing evidence that alcohol is related to poor health, including cognition, but mostly cardiovascular and cancer risk. And so guidelines across the world have been lowering their recommended limits. And that brings us to the most recent guideline of, I think this came out in July or August 2022 from the Canadian Centre on Substance Use and Addiction. And they are now recommending less than 2 units per week for women and men. And that is 2 units, I'm sorry, 2 units per week, Canadian units. And I will just highlight here that 1 glass of wine does not necessarily equate to 1 unit. So actually, 1 glass of wine, for it to be 1 unit is only 5 ounces. But when you go to a restaurant or a bar and you order a glass of wine, the small glasses are usually 6 ounces and the large ones are 9 ounces. So that's important for us to be aware when we're counseling our patients. Sorry. So that brings us to our paper, Associations Between Moderate Alcohol Consumption, Brain Iron, and Cognition, published in PLOS. And they were trying to answer some of these questions. So they asked, does moderate alcohol consumption, I'm so sorry. Does moderate alcohol consumption mediate iron deposition in the brain? Is alcohol-related iron deposition a mechanism for cognitive impairment? And the design here was a prospective cohort study, and they performed their analysis retrospectively. The population was UK Biobank participants, and we'll talk about them in a minute. They were otherwise healthy adults from the community aged 40 to 69. The exposure was alcohol consumption, and they separated their population into quintiles of alcohol exposure. And comparator was the group, the lowest quintile of alcohol consumption, and they were consuming less than 4 units per week. The primary outcome was brain iron deposition, and secondary outcomes were systemic iron deposition as they measured in the liver, and cognitive measures. So the UK Biobank is this massive database of 500,000 people in the UK recruited from 2006 to 2010. And they have a whole host of health information, including alcohol, cognition, and genetic analyses on these patients. So for alcohol, they reported this at baseline recruitment. They had the patients use a touch screen and answer a question about their current alcohol intake. So importantly, they did not ask or did not document any historical or lifetime history of drinking. And of their whole sample, never drinkers comprised only 2% of the sample. For cognition, they assessed fluid intelligence, prospective memory, digit span, and pairs matching. And then of that huge sample, some patients, it's not clear exactly who, went on to get MRIs of their brain. And of those, there was about 20,000. And of those, almost 7,000 went on to get another MRI of their abdomen, looking at their liver for liver iron. And among the patients that had the MRI scans, they had a bit more cognitive testing, including trails A and B as a marker of executive function, shape task for memory, and logic questions for fluid intelligence. So there's a lot here in table 1, just to give us a sense of who the participants were. I'll describe a typical patient as a 55-year-old man or woman. There's a pretty good balance, high school graduate, mild obesity, consuming about 10 units of alcohol, Canadian units, 10 units per week. So 1 or 2 units per day. Now, the authors performed 3 different statistical analyses, and they're outlined in this diagram on the right. So the first one was observational analysis. They were looking for an association first between alcohol consumption and brain iron. Then they performed a second analysis looking at the association between brain iron deposition and cognitive outcomes. That was the observational analysis, and we'll talk about that again. Secondly, they performed a causal mediated analysis. In the causal mediated analysis, they were looking at that association from alcohol to brain iron and trying to figure out how much of it was mediated by elevated body iron levels for direct and indirect comparison. And thirdly, they performed a Mendelian randomization, and that's where they looked at different genetic variants that could be implicated in this picture and how that may have impacted alcohol consumption, body iron stores, and brain iron deposition. So for the first one, the observational analysis results, they first looked at alcohol and brain iron association, and they saw that alcohol of more than 4 units per week resulted in higher brain iron. So that's anyone that was outside of that lowest quintile reference group. And they saw this most significantly at the bilateral putamen, and you can see in the diagram here, we've got little dots representing the different brain regions, and there's the highest dots that are in green in the putamen, and they're almost off the chart. The caudate in pink, the substantia nigra in blue, and then they reported lower iron levels at the thalamus among moderate and higher drinkers. And they did, I just want to highlight that they did include multiple confounders as covariates in their analysis, including age, sex, smoking, education, BMI, BP. They actually had a huge list, and it looked quite comprehensive. And then for their second observational analysis, the link between brain iron and cognition, they saw high brain iron levels at the hippocampus and pallidum were associated with slower trails and lower fluid intelligence. They also noted that advanced age on its own is associated with slower trails. So when they added age in as a variable, they saw an association with age plus alcohol plus high brain iron, resulting in slower trails. And that's what we're seeing in graph A on the right and in graph B. So overall, high brain iron and high alcohol intake looks like they exacerbate age-related changes in executive function. But I wrote here to a very small degree because you can see that the line from age and trails is pretty linear, and you almost have to squint to see the different lines which represent alcohol consumption and brain iron. At least I have to squint. So secondly, they performed a causal mediated analysis, CMA. So for this, they considered that their observational analysis had already established an association between alcohol and brain iron, and now they were taking the next step to elucidate the mechanisms of alcohol iron association by triangulating the observational analysis to determine direct and indirect causality. So here they were looking at alcohol consumption as the exposure, the outcome as brain iron, and then in green, you can see they were considering body iron as the mediator, and they measured body iron as amount of iron on liver MRI. And for this result, they found that alcohol consumption of more than 6.5 units per week resulted in higher systemic iron, and that was associated with higher brain iron. Just to put the numbers to it, 1 standard deviation increase in alcohol consumption resulted in a very small increase of 0.05 milligrams per gram increase of liver iron, and then a larger increase of liver iron of 1 milligram per gram resulted in half a standard deviation of increase in brain iron, particularly at the left putamen. Their conclusion from this analysis was that alcohol's effect on brain iron is 32% indirect via high systemic iron and 68% a direct effect of alcohol directly to brain. Thirdly, they performed a Mendelian randomization. This was a new approach for me, and I'm not sure how comfortable everyone in the audience is with it, so I'm just going to spend a couple slides explaining it and putting it into the context of this presentation. Mendelian randomization is when you use genetic variants as instrumental variables to investigate effects on modifiable risk factors like alcohol drinking or cigarette smoking or et cetera. So it's a novel approach. I think this has only been out for the last 10 years or so, when we're using observational data to determine causality. So this changes what I initially had learned in medical school, that observational studies are for generating hypotheses. Here they're using it to determine causality. And it's being used increasingly when randomized control trials might be unethical or just too costly. So maybe we'll be seeing more Mendelian randomization in the future. The premise of it is that we all have a chance distribution of genes within a population. And we know that from genome-wide association studies. When you combine that with these large data sets that we've got, like the UK Biobank, then you can use some statistical methods to pull out a causal relationship between the two. So for this study, the genes they looked at were those associated with alcohol use disorder. So looking at alcohol metabolism, dopamine metabolism, and the reward pathway, and how those could impact brain iron deposition. And they also looked at the HFE gene alleles for iron metabolism and how those impact systemic iron that we know can mediate brain iron deposition as well. For the data set, we used the UK Biobank, and they looked at alcohol consumption, systemic iron, brain iron, and cognition. So for Mendelian randomization to work, it requires 3 different assumptions. And this is where we'll go through them, and then you can, we can all discuss at the end whether we're believers or not believers in this method. For it to work, we need the relevance assumption. The relevance assumption assumes that genetic variants associate with the risk factor of interest. So for this paper, we'd be assuming that genes dictate your alcohol intake. And we know, and the authors even mentioned that that is not true, that alcohol-related genes only account for 1% phenotypic variation in alcohol consumption. Second, there's the independence assumption. This assumes that there are no unmeasured confounders of the association between the genetic variants and the outcome of brain iron. And I think that's a pretty high bar, in my view, to set, to assume that there are no unmeasured confounders, and it's not clear to me whether or not there are. Lastly is the exclusion restriction, and this assumes that genetic variants affect the outcome only through their effect on the risk factor of alcohol intake. So for this paper, that means that the genes have zero impact on brain iron directly, that they only affect brain iron deposition through alcohol after controlling for iron homeostasis. With all that in mind, the authors performed their statistical analysis and concluded that there is a causal association of alcohol use disorder gene polymorphisms with high serum iron markers as another indicator of high systemic iron. And they reported a trend toward alcohol use disorder genes and high brain iron at the putamen specifically, but that did not stand up with multiple different models, because there's different ways you can run Mendelian randomization. And so it was sometimes found, but not conclusive. Overall, the authors conclude that moderate alcohol consumption, more than 4 units per week, Canadian units, results in high brain iron, and high brain iron leads to cognitive impairment, particularly executive function and fluid intelligence. So now we get to come on to the critical appraisal. So we use the CASP checklist. Looking first at validity, did the study address a clearly focused issue? Yes, it did. They looked at alcohol, iron, and cognition. The cohort was recruited in an acceptable way through the UK Biobank. Was the exposure accurately measured to minimize bias? And the answer here is no. Alcohol consumption was really the crux of this whole paper, and they did not rigorously measure it. They asked one self-report question on a touch screen about current drinking and nothing about historical or lifetime drinking exposure. Was the outcome accurately measured to minimize bias? And here, unfortunately, the answer is also no. They, again, the crux of their paper on brain iron was dependent on what they saw on MRI scans of the brain, and MRI brain iron cannot be easily distinguished from myelin on MRI. So we can't say for sure that what they saw was even due to brain iron and not myelin. Have the authors identified all important confounding factors? They had a lot of information to go on from the UK Biobank data, and I think they Yes, they did, and they did include that in their linear regression models as covariates. Was the follow-up of subjects complete enough? Well, that's unclear. They did not provide a lot of details about how they followed up subjects. I'll remind you back in the diagram of how they performed their recruitment and measures, that they performed cognitive follow-up at about 5 or 6 years in a subset of patients, but they didn't describe how they found that subset. And was the follow-up of subject long enough? Well, maybe the follow-up was for cognitive measures was around 5 to 6 years. And this was in a cohort of patients aged 40 to 69. So it's not impossible in my mind that we might have seen some early cognitive changes with alcohol consumption at the 5 or 6 year mark, but I would expect minimal and maybe even no change. What are the results of this study? So they reported that moderate alcohol consumption, more than 4 units per week, increases brain iron and impairs cognition. They were very small effects, and that effect increases with age. The results had narrow confidence intervals for their reported outcomes, so the results were precise. And overall, I do believe these results, but I think the effect is very minimal. I wonder if the effect would have been greater if their reference group was never drinkers instead of the lowest quintile that drank less than 4 units per week, because unfortunately now less than 4 units per week doesn't even reflect our Canadian guidelines. So it would be nice to see this updated in that respect. And can the results be applied to the local population? Well, no, they did not include ethnicity in table 1. So even for the basic alcohol consumption to brain iron to cognition analyses, I can't confirm that. And certainly for the Mendelian randomization findings, those were specific to those with European ancestry. So it's unclear how those findings would relate to other populations. Do the results of the study fit with other available evidence? And the answer is yes, it does. And it fits with our whole trend over the last several decades of finding increasing harm at lower and lower levels of alcohol consumption. So what's the bottom line? How will this study impact my practice? Well, when I think back to this case of a woman who's drinking a glass of wine per night, my new recommendation for her will be alcohol does impact the brain adversely. There is no known safe amount of alcohol, and therefore she should drink no more than 2 glasses of wine per week in line with our Canadian guidelines, but I would want to check the size of her glass. Future areas for future research might include exploring that direct effect of alcohol on brain iron accumulation. Could it also be related to low thiamine levels? Exploring mechanisms of how brain iron impacts cognition, because that's still unclear. And then figure out what's going on in the thalamus. Why would higher alcohol consumption cause lower iron levels in the thalamus? Was that just chance? And can these findings be replicated in non-European populations? So that pretty much wraps up my slides. I'm open to any questions now.
Thank you very much, Rachel. What a beautiful presentation. And I echo the comments in the chat box from Shabir and Gary. The context was great, translating a fairly dense paper and explaining Mendelian randomization. Simply great. Perhaps we have time for one quick question from the audience, but otherwise we'll have to, for time considerations, move on to the long presentation. If there are no questions, please. Oh, Gary, go ahead.
Rachel, thanks. Great job. Just a quick question. Were you completely convinced about the relationship alcohol to iron to cognition? Why couldn't it be that alcohol simultaneously causes increased iron, but also the alcohol itself directly relates to perhaps some cognitive findings that were very small, as you pointed out? And if you had to squint, I can't tell you what I had to do, but.
I think that's a fantastic point. And the mechanisms there, as we said, are not clear. So, and the findings, it was so minimal. I echo, I'm not, maybe there's an effect that's so minimal directly coming from the brain iron deposition. I suspect, especially at higher levels of consumption, that regardless of iron, alcohol is going to have an adverse impact on cognition. I agree.
And were you convinced, because of interest, the iron deposition was not, for example, in the hippocampus? It was largely in the basal ganglia.
Right.
Were the cognitive tests that exhibited cognitive impairment commensurate with the brain region, i.e. disproportionately not perhaps memory related, but more executive attention related?
It's a great question. So I think when they designed the study back 10 years ago, I don't think they had this in mind, and you could tell from the way they were doing their analysis. So the cognitive measures, I think, were not very rigorous, especially to draw such a conclusion that they drew. They completed trails A, trails B. They asked a few logic questions. It's really not clear exactly what those cognitive measures were, but they were certainly not standardized tests. So I don't even think that we can pull out that degree of brain localization to what they performed.
Thank you very much for the questions and a few more comments in the chat box, Gabby. We will transition Dr. Gabriella Jacob, PGY4 Geriatric Medicine resident. A warm welcome for her first presentation at Journal Club. Gabby also has a keen interest in QI. Over to you, Gabby. You're still muted.
Sorry about that. Good morning, everyone. Thanks for the kind introduction. And today I'm going to be speaking about music interventions for dementia and depression, specifically the MIDDEL trial, which was a randomized control trial looking at 2 different music interventions in the long-term care population in Australia. Just to get started, I don't have any conflicts of interest to disclose, but I will state that music has been a big part of my life from a young age, as you can see here. So that was why I was interested in presenting on this. So the objectives for my talk today are to first do a brief overview of dementia and depression. I'm going to provide some background on music interventions in dementia and review the literature for the 2 main types of interventions that are described in the literature. I'm going to outline the methods and results from the paper that we will discuss and provide a critical appraisal, followed by some future directions. So in terms of music for dementia and depression, as we all know, dementia and depression are very common in older adults in long-term care. They frequently coexist, and a CHI report from 2015 to 2016 found signs of depression in 31% of residents with dementia in long-term care. Now, there is a complex interrelationship between depression and dementia. We know that patients with depression have an increased risk of developing dementia. Also, the depressive symptoms can develop from the dementia pathology itself. And while treatments have long focused on pharmacologic therapies like antidepressants, there are risks of side effects with that. And that has led to efforts to determine effective non-pharmacologic options for treatment. That brings us to music. And music's an area that has been really interesting for researchers because they found in studies that musical memory can be preserved even in advanced dementia. And studies have looked at different brain areas that are involved in music memory, and they found that these are relatively preserved in the brains of patients with Alzheimer's disease and other dementias, particularly the areas of the caudal anterior cingulate and the ventral pre-supplementary motor areas that encode musical memory seem to be less affected by atrophy. And so there's been notes that persons with dementia remain receptive to music, even in the late stages of their disease, and that they have a remarkable ability to remember old songs and familiar tunes. So that has led to the interest in looking at music and the effects of music to help invoke emotional responses, to help with retrieval of memories, and to help with stress reduction and mood. So music has been looked at in the literature to explore its effects on cognition, behaviors, emotions, and biological and physiologic effects, with the goal really of seeing whether it can improve overall well-being and quality of life. A lot of these studies have been quite small and not not necessarily highly rigorous or randomized control trials. There are two types of music interventions that I want to outline now, so we all know what we're talking about when I refer to these. The first is music therapy. These are interventions that are usually delivered by a music therapist. They're delivered to individuals or groups, and they are combined different interventions. So there's really a lot of heterogeneity between what can be offered. They can be receptive, so the participants listen to music. It can be active. They might play along with instruments, sing along. The goals of this are to build a therapeutic relationship between the therapist and the participant and to meet their psychosocial needs. And this helps to improve communication skills, to try to regulate the affect and emotions of the individual. Now, in contrast, recreational choir singing is something that is performed by choir leaders, musicians. It is done in groups. They focus on singing songs and learning new ones. So the goals here are also focused on activating cognition because you're learning new material. You're really focusing on getting down the melody, the lyrics, and the rhythm. And they're also trying to focus on community, feeling connected to others, and improving well-being. Now, in the literature, music therapy has been studied more so than recreational choir singing. And when they did study this, they found that it probably reduces depressive symptoms in a Cochrane meta-analysis from 2018. Now, this involved 9 RCTs and 376 participants from the US, Europe, Asia, and Australia. And many of the trials on an individual basis did not have statistically significant results. As you can see from here, these confidence intervals here, many of them were not, but pooled together, this meta-analysis did show favorable results. And so overall, the reduction in depressive symptoms was seen at the end of treatment, but unfortunately not in the long term. And this was rated as moderate quality evidence. Just so you know, the depressive symptoms themselves were measured by depressive rating scales like the GDS or the Behave AD. Limitations, of course, of these were small studies. There was different interventions offered, and there are different outcome measures that were used. When this meta-analysis was done, they also looked at other outcomes like anxiety, social behavior, which was rated as very low quality evidence. There was a high risk of bias for those two outcomes. And there wasn't any change seen in emotional well-being, behavioral problems, or cognition. And that brings us to recreational choir singing. So there's more limited literature in this area. It might improve cognition and mood. One study was not able to show a significant difference, but this was done with an extremely small sample size of about 10 participants. Whereas Sarkamo et al. In Finland was able to demonstrate a significant improvement in mood scores and cognition at the end of treatment, using the Cornell scale before and after treatment. But again, this was not sustained long-term. And these studies were all done in community dwelling adults and usually earlier stages of dementia. Now, this final trial here was the only trial I found that actually directly compared group music therapy to recreational choir singing. It was done by Werner et al. In 2015, and it looked at participants who were in nursing homes. And they actually found that participants who had music therapy had a reduction in depressive symptoms, and that's this red line here, of about 2 points on a scale known as the MADRS. And the patients or participants who had performed, in choirs or did singing actually had worsening in their depressive symptoms. Again, there was no placebo arm in this trial. They actually considered the placebo group to be those who did choir singing, which was interesting. And that brings us now to this study. So this study is published in The Lancet and just in March 2022. And it's an Australian cohort of an international cluster randomized trial that is aiming to recruit 1,000 participants There are 5 European countries who are also taking part, and those results are still pending. The goal of this trial was really to look at the music interventions and which is effective. Is it group music therapy or recreational choir singing, and compare them head to head. So they wanted to study the effects of group music therapy or recreational choir singing compared to standard care, and to explore whether there are synergistic effects of having group music therapy combined with recreational choir singing. Their hypothesis was that group music therapy and recreational choir singing may differ in the pattern of effects because they do affect different domains. They felt because of these downstream effects that group music therapy would be superior to no group music therapy. Recreational choir singing would also be superior to no recreational choir singing. They also noticed that in the previous studies, group music therapy focuses on affect regulation and processing of life experiences with the hopes of reducing aggression, agitation. And as a result, they felt that group music therapy may be more beneficial for patients with more moderate to severe dementia and late stages of dementia. And finally, because these do work on different pathways, and recreational choir singing might have some additional benefits like cognitive activation, biological effects because of the training of the singing, that together they may have synergistic effects. So that brings us to how did they do the study? So they recruited participants who are over age 65 with dementia, who are living in residential aged care facilities in Melbourne, Australia, which would be equivalent to our long-term care. They looked at group music therapy versus recreational choir singing. They also had an arm that had both interventions offered, and they compared that to the standard of care. And their outcomes were depressive symptoms at 6 months. The interventions that were offered were group music therapy in 8 groups of 8 to 10 people conducted by a music therapist. And the group music therapy was actually involved singing, playing musical instruments. They also had a 20-minute initial assessment to get to know the individual, to know their music preferences and choose the appropriate music. And the goal was to meet the psychosocial needs of each individual resident in the moment and include familiar songs, music simulated reminiscence, improvising on percussion, and spontaneous or directed movement to music. In contrast, recreational choir singing was conducted by a community musician who had some training from a music therapist. This was done in larger groups of 15 to 20, and it was focused on singing familiar and preferred repertoire. And they had lyrics displayed on a screen. They did brief physical and vocal warm-ups, and they learned new musical material as well based on the needs and abilities of the group. Of note, this was open to residents who were not in the trial as well. The inclusion criteria were patients over age 65. They needed to have a diagnosis of dementia, which they stated in their in the paper was based on an assessment by a neuropsychologist. They needed an MMSE less than or equal to 26 and a clinical dementia rating scale that ranged from 0.5 to 3. So just to give you a sense, a CDR of 0.5 would be someone with slight impairment of IADLs, but completely independent for their ADLs, whereas a CDR of 3 is someone who is fully dependent for personal care. So this essentially spanned patients with mild all the way to severe dementia. And they looked at, they needed to have at least mild to severe depressive symptoms based on this Montgomery-Åsberg depression rating scale called the MADRS. And I will speak about this very shortly. They excluded patients with schizophrenia, Parkinson's disease, hearing impairment, and someone who wouldn't be able to sit through the sessions. And it was designed as a 2x2 factorial design, which means they looked at 2 different variables, recreational choir singing and group music therapy. And they wanted to explore the combination of the 2. So they ended up having 4 arms of the trial. They had participants who only received group music therapy. They had participants who only received recreational choir singing. They had a group who then received both, and then a group who had neither, or their standard of care arm. And the trial was designed as a cluster randomized trial, which means that each care home unit was together randomized to one of these 4 conditions. So an entire unit of 10 or more participants would receive one of these 4 interventions. They were randomized in 5 waves. So there were actually 5 different waves of the study that were conducted. And that means that one wave had 4 units in the study at a time, with 1 unit per arm of the trial. Now, the main comparators they set up were group music therapy versus no group music therapy, and recreational choir singing versus no recreational choir singing. So as you can see here, I've outlined that the group music therapy group actually included the arm that had both, as well as the arm that had only group music therapy, compared to those who received only recreational choir singing or standard care. And vice versa for the recreational choir study arm. When they looked at RCS, they looked at the group who received both, as well as just recreational choir singing. And then they compared that to those who had standard care or just group music therapy. And the rationale they gave was that they wanted to maximize the statistical power for the study, as it was a smaller study of just the Australian cohort. It was designed as an intention to treat analysis. This is their protocol for the interventions. They, in the first 3 months, did twice a week group music therapy or recreational choir singing. The combined arm here received 2 times the amount of intervention. So they actually received twice a week group music therapy and twice a week recreational choir singing. The standard of care arm received the typical leisure programs offered at the recreational facilities, such as group games, entertainment, classes like arts and crafts, gardening, and outings. In the later months, 3 to 6, there was once a week, but again, in the combined arm, they received 2 times the amount, so once per week of each. And that led to a total number of sessions, as you can see here. The primary outcome was depressive symptoms at 6 months, based on the Montgomery and Asperger Depression Rating Scale, which is a 10-item scale. As you can see, it includes these 10 components, which are rated between 0 and 6. The score then therefore ranges between 0 and 60. And this is actually done by an external masked assessor in this trial. Here's an example of what would be considered mild, moderate, and severe depression based on this scale. They had a number of secondary outcomes, which included neuropsychiatric symptoms, quality of life scales, as well as scales to measure staff burden. These are their baseline characteristics. So they ended up recruiting 318 participants in 20 care home units. That ended up being about 80 residents in each arm of the trial. They were approximately 2/3 female, with an age of about 86.5 years. And most were born in Australia. Most had English as a first language, but they did have some diversity in the trial. Some participants from Europe, Australasian countries, and about 16% having a language other than English. 80% had moderate to severe dementia, and their average MMSE in the trial was 8, with about 1/3 having a diagnosis of Alzheimer's disease. The remainder had other dementias or unspecified dementia. In terms of the groups, they were fairly well balanced. I've just noted some things that stood out. In particular, the combined arm had a more single or unmarried. They also had, the group music therapy arm had slightly less people with primary education or less. And group music therapy arm also had slightly more with Alzheimer's disease diagnosis. So that brings us to the results. The first hypothesis they had, group music therapy versus no group music therapy. In this trial, group music therapy in their factorial analysis was not superior to no group music therapy. So here on this graph, you can see the depressive rating scale for group music therapy. If you can see that blue line, which is a little bit hard to see, but it did go down. Depressive symptoms went down, but these results were not statistically significant at any of these time points, 3, 6, or 12 months. In contrast, recreational choir singing was superior to no recreational choir singing at all 3 time points. So at the 3, 6, and 12-month mark, the scores on the MADRS went down by 4 to 5 points. And this is the recreational choir singing line here, the red line, which you can see diverges from the other lines. Now, they did look at the subset with moderate to severe dementia in a separate analysis. And in this group, the group music therapy arm was actually superior at 3 months. But again, at 6 and 12 months, this lost statistical significance. And recreational choir singing still maintained its superiority at all 3 time points, with a reduction in the depressive rating scales of about 5 to 6 points. In their factorial analysis, there was actually no synergistic effect seen between group music therapy and recreational choir singing. So although the combined arm received twice the dose of intervention, there was no further increase of effect seen. If participants attended more than 50%, this led to larger treatment effects, but still only recreational choir singing remains statistically significant at all 3 time points. They also did perform an exploratory subgroup analysis because of COVID lockdowns affecting their 5th wave of the study. And they did find similar results to the main analysis, which they felt meant that their main analysis remained robust despite the issues with the data in the wave 5. In terms of secondary outcomes, recreational choir singing was superior at 3 and 12 months compared to the other arms. For caregiver distress, it was recreational choir singing at 3 and 12 months and group music therapy at 3 months. So as you can see, even the group music therapy arm did reduce at 3 months, but then unfortunately did go back up at 12 months. Quality of life measures, these weren't as significant. In fact, none of them were statistically significant except for one of the quality of life measures at 1 time point. And of course, both of these interventions meant there was increased burden on staff as measured by the staff rating scales. There were no serious adverse effects from the interventions, but they did note 2 non-serious events that are stated here, mostly related to behaviors from the participants' underlying dementias, and none resulted in any injury. So the author's conclusions were that recreational choir singing led to a clinically meaningful reduction in depressive symptoms, and this was a lasting effect that was seen up to 12 months, which is new, something that has not been seen in the literature before. Unfortunately, group music therapy did not have this effect seen, but the subgroup analysis did suggest that there's benefit in the more moderate to severe dementia cohort. They question whether there's an interaction between the severity of dementia, attendance to sessions, and intervention itself. And there was no interaction found by offering both interventions together, but they do want this to be looked at further in the full international trial. And that brings me to the clinical appraisal. So in terms of the validity of the trial itself, the trial was addressing a clearly focused issue. So they looked specifically at 2 music interventions for depressive symptoms in dementia. They did assign patients in a way that it was randomized through a computer-generated randomization list. Were patients, health workers, and study blinded? So the assessors were masked to treatment allocation, but the interventionists, residents, and care staff were not able to be blinded after they had been assigned to a specific arm of the trial. Were the groups similar? I said maybe. Again, I did note there were some more single in the combined group. Again, that might affect depressive symptoms, a bit of imbalance in the baseline education level, and some more participants with Alzheimer's disease in the group music therapy arm. But overall, otherwise, they were fairly well balanced. Were they treated equally? I said maybe. They did track participation in recreational activities that were outside of the trial, and they were similar between all of the groups in the trial. But there is a possibility, in my mind, that there's a difference in care because they're all taking place in different care homes and different care units. So perhaps there's a difference there that could account for some difference in depressive symptoms. Were the interventions delivered equally between the groups? So I was wondering, was attendance similar between the groups? Did people actually go, and were they delivered properly, the interventions? And yes, there were a similar number of sessions attended in all arms of the trial. And again, of course, the combined arm, there was approximately 2 times more sessions that were attended in that arm of the trial. And they did assess fidelity with checklists. And they found that 100% of the group music therapy arm was conducted properly, and 94% for the recreational choir singing. And they did also have recordings of the sessions, and they used those checklists to determine if they were conducted appropriately. So was follow-up complete, and were there differences between groups in terms of follow-up? So unfortunately not. The COVID pandemic actually led to dropouts with data missing not at random, and only the 3-month endpoint ended up being valid for all 20 clusters for the analyses. And at the 6-month time point, I noticed that the group music therapy arm and standard care arms had significantly less participants due to outbreaks. So 58% and 62.5% compared to 76 and 72%, and that might have affected the analysis as well. They do state that they tried to introduce mitigating strategies like modified assessment procedures and changes to the analysis plan. And they did complete this exploratory subgroup analysis to exclude the 5th wave, which was affected by these changes. And they found similar results. So that's what they used to explain the fact that they felt that the data was still valid. Of note, they did look at residents who dropped out of the trial before the 6-month time point, and they found that they were relatively similar, except they had more severe cognitive impairment and depressive symptoms. So that is something to keep in mind, that patients or participants who had more severe depressive scales and more severe dementia were actually more likely to drop out of the trial. So participants were analyzed in the groups in which they were randomized. This was done as an intention to treat analysis. And the study was stopped early. This was due to the COVID lockdowns in Australia. They were planning to have another wave of the trial rolled out, but they felt that they were not able to gain access to the facilities and therefore stopped the trial early. Were the outcomes measured in the same way for the treatment groups? So yes, they used masked assessors, and they used a depressive rating scale, the MADRS. Were they measured in a reliable way? So I would say yes for the primary outcome, because this was a validated scale that was performed by trained masked assessors. They did need to partly rely on information from care staff in order to complete this. And one of the things that was brought up, especially for the secondary outcomes, was that they were relying on care staff as proxy respondents. And when they would ask the care staff about behaviors, they apparently had some trouble understanding terminology. And that does raise the question of whether these secondary outcome measures are reliable. So what were the results? So how large was the treatment effect? So I said this is small, but clinically relevant. So the change in the MADRS score was about 4 points. Again, this is larger than that trial that I mentioned before by Werner et al., which found a change of about 2 points. What in the literature is considered, has been defined as a minimum clinically important difference, means the smallest change in a scale to which the participant notices a difference. That has been defined as 1.6 to 1.9 change from baseline. But again, like remission from depression would be a much larger change in the MADRS score, not just 4 points. How precise was it? Well, again, this was low precision. Their confidence intervals were quite wide, but it did remain statistically significant. Will the results help locally? Well, maybe. I said it was done in Melbourne, Australia, which is a multicultural city, and there was some diversity in the population, but again, it was predominantly English speaking. Participants were generally of European descent. It was done in an LTC population, so could be applied to that, but not to community dwellers. And the larger randomized control trial in Europe may be helpful to determine the generalizability. Were all clinically important outcomes considered? I felt that they did do a good job of looking at a variety of outcomes: neuropsychiatric, quality of life, caregiver burden. But interestingly, they had no family involvement. So all their proxy respondents were care staff. And I feel like family involvement is something that also could be looked at in future studies. Are the benefits worth the harms and costs? I would argue yes. It is very low risk for harm and a potential benefit. The cost is certainly less with recreational choir singing. It's definitely more easily scalable to larger groups, and it can be delivered by community musicians or those with less training as opposed to a music therapist. And I'd anticipate the cost would be relatively comparable to other recreational activities. So in terms of future directions, certainly the larger international trial results are pending and will be helpful. If they do replicate these findings in the full trial, it could help to determine the generalizability of these interventions. Certainly, it's the first trial that showed recreational choir singing was effective in moderate to severe dementia. And so hopefully that could be used to advocate for more of these music interventions in the long-term care setting and to help improve quality of life, depressive symptoms, and overall well-being. So I would like to open the floor to questions, and thank you for your attention.
Thank you very much, Gabby. What an exceptional first presentation. Seemed like you've presented many times before. That was wonderful. The context was great and the critical appraisal as well. We have a few moments for questions. I'll open it up to the audience. I have a comment in the chat. Great job, Gabby, from Gary. I might ask, I was a little bit surprised that the severity of the dementia on average, and those participants were able to participate with the choir group. And so an MMC of 8, but I would have expected they would have participated well with the music therapy, but with a choir type ensemble, it would be a greater challenge. And so that struck me as interesting.
Yeah, I think that's really interesting interesting for me as well. And I think that's something that also was a reason that it had never really been tried before, because I think people felt that they wouldn't be able to do it. I do wonder also whether the fact that they had people who weren't in the trial there, also just, those people may have been more able to participate and help others to follow along. And they did use, I think they used screens with large text with the song lyrics. So even maybe just being there and listening to songs they liked, perhaps, it's hard to know really, but.
Oh, and Gary has his hand up, go ahead.
Thanks, Gabby. I don't know, it's the methods and things were dense. I have a variety of concerns. I mean, it's a very broad range of dementia severity, very broad range of depression severity, no active controls. I wasn't quite clear how they took into account the cluster effect, but I'm going to ask one thing based. I did a study led by Pia Contos on clowning, adult clowning for behavior management. Mm-hmm. And one of the interesting things that came out in the literature about clowning is the impact it had on the care staff, not just the patients. It raised the moods of care staff. Mm-hmm. So I wasn't quite clear whether the larger choirs may have generated more music on the units and had a positive effect. That then becomes significant because they called it masked assessors of the primary outcome. But as you pointed out, but they had to get some proxy information. So that's not like, I think that's false advertisement. That's not a pure blinded outcome assessment of the primary outcome. And then the question I had in my own mind is, did these large choirs possibly raise the mood on the unit, and the proxy assessors, their mood was elevated, so they tended to increase the mood. So I think it's a complex study design, and I'm not thoroughly convinced of the result, although like you say, the potentially the cost to doing it and adverse effects are essentially nil. You may consider doing it, but I have a lot of questions about the methods.
Yeah, the factorial design was something that I was like, I had not really had much experience with before. And I also wondered, the question that choice as well. But I guess they figured out before that if they had analyzed them within each of the 4 arms separately, they wouldn't have been able to show a statistically significant difference.
Is it frozen? I think Gary may have frozen, but oh no.
No, I'm not frozen. I have my heater on, so I'm good. No, we don't really have time to get into it, and others on this call are even certainly more knowledgeable than I about some of these methods, particularly cluster methodology and accounting for the cluster. But interesting study, obviously, and you hope it's a real finding because it would be good.
Thank you very much. We're a few minutes after the hour. I want to thank both presenters this morning for absolutely great presentations. By way of announcements, please do fill out your evaluations that were sent to your email moments ago. And also a reminder, next week, Friday, the UHN Sinai Geriatric Medicine Update course. I think today is the deadline to register for that. And happy Halloween.
Dov, can I just have the group look at www.drivinganddementia.ca, which is a new website that we've launched to support the issue of driving cessation in dementia, and love your feedback.
Thank you for that announcement as well. I can put it in the chat box, and most of you, there you go. And most of you should have received that email as well earlier. And thank you, Rachel, for putting it in the chat box. Have a great day, everyone. Thank you, Rachel. Thank you, Gabby.